Thank you so much for that kind introduction. Yes, I wear a couple different hats, one of which is critical care. I'd like to thank the chairs for the invitation to give this talk, and that was a really great introduction to my talk, which is FES exam, the value added to surgical education. I have one disclosure, which is Boston Scientific. I'm a consultant and a speaker. I'd like to start with this quote: "Flexible endoscopy is a central component of surgical history and is necessary for quality, comprehensive care of the surgical patient." I frankly stole this quote because I couldn't really say it any better myself. This was from an editorial published in 2013 on why fundamentals of endoscopic surgery, and really was written by many of the surgeons that had a huge piece in the creation of FES. So to go back a little bit on the history, the question really becomes, is endoscopy really a core component of what we do in general surgery? And in 2002, Rosen and colleagues found that in academic surgical practices, endoscopy volumes made up about 12% of their gross billings, but was really only generated from about 8% of the work that they did. This was followed up in 2005 with another study that really looked at community surgical practices, and their endoscopy volumes made up over 50% of their cases, with over 40% of their total charges. And then subsequently in 2013, endoscopy was found to be the second most common procedure performed by rural surgeons. So in terms of the history, in 2006, the American Board of Surgery mandated that in 2009, the number of total endoscopy cases were going to be increased to 35 EGDs and 50 colonoscopies. And then this question really became, is this an adequate benchmark? Many of the gastrointestinal societies kind of put this question out to the American Board of Surgery, and this question of whether or not this was adequate training and competency for endoscopists coming out. Subsequently, in 2012, there was an institutional study performed of a set of PGY-5s. I think it was actually 4s and 5s. And they said that endoscopy was really relevant to their practice, but they were generally speaking uncomfortable doing it. 23% of them were not confident doing EGDs, and 50% were not confident in doing colonoscopies. This was followed up by a national study that was performed of general surgery chief residents, about 300 of them, and very similar results: 30% not confident in upper scopes, 50% not confident in lower scopes. So then there becomes this question of what is really an adequate number of endoscopies. And I'll generally say there is a lack of consensus over this, but the American Board of Surgery endoscopy numbers were really largely on the basis of this study done in 2001 of about 13,000 colonoscopies, when they really looked at these endoscopists at what percentage or at what volume did they reach the cecum at over 90% with minimal complications and in less than 30 minutes, and that benchmark was at about 50 cases. Subsequently, there have been many studies looking at what this benchmark should be. The ASGE, in their 2017 guidelines for their fellows, states that their numbers are 275 for colonoscopies and 130 for EGDs. But what we've really found is that case numbers might not be a good surrogate for competency. And so subsequently, the ABS, in conjunction with SAGES, developed the flexible endoscopic curriculum to assess skill and knowledge, along with the SAGES fundamental endoscopic surgery certification. And this was implemented for the graduating class of 2018 to be board eligible. And so the FES was developed with validity as a high-stakes test to identify a minimum level of proficiency for candidate. So I thought this was all really important to kind of give the background of the impact that FES has made on surgical education. The certification exam itself, as many of us know, is a web-based multiple choice exam, and then subsequently a hands-on virtual platform where endoscopic skills are tested in these 5 specific skill sets, and both of them have to be passed to fulfill the, to get FES certification and for the FEC requirement. This study was published before FES was really implemented. It looked at, is what we have currently in surgical training adequate enough for our residents to pass FES? This was published in 2016. It was done on general surgery residents along with GI fellows. It was prior to implementation of any sort of proficiency-based training. And all of the residents and fellows that participated had met their endoscopic case requirements. And the overall pass rate was 75%. General surgery residents' pass rate was 68%, GI fellows' pass rate was 85%, and they most struggled on loop reduction. And in this study, the minimum number of cases associated with a pass rate was incidentally 103 cases. So it seems like maybe a curriculum really is necessary, and that maybe sheer clinical experience, at least based on our case requirements, may not be enough alone to pass FES. And so this question becomes, has FES changed surgical endoscopy education? And I would say hands down, absolutely. The creation of the endoscopy curriculum, it's helped with the creation of an endoscopy curriculum in general surgery programs when it never really existed before this. There are dedicated endoscopy rotations now. It's helped with the creation of endoscopy skills training labs in those programs that feel like they need it. Really identify dedicated surgical faculty to teach endoscopy and really be champions of that when it didn't necessarily exist in many programs in the past, and then create affiliations with our GI colleagues in places where that was necessary. One of the things that FES has really helped is really paving the way for endoscopic skills curricula. In places that have developed skills training labs, it's really been established that proficiency-based training is really optimal for simulation. This really helps ensure uniform skill acquisition, which can also be transferred to the clinical setting, and that this helps retain those skills over time. And there's a lot of different models that are being used, mechanical models, animal models, and computer-based models. To go a little bit on this kind of proficiency-based training concept, this study was done at our institution before FES was implemented. A set of residents were tested on FES prior with a pass rate of about 53%. A proficiency-based skills training was implemented, and then FES was taken again by these set of residents, and their pass rate went from 53% to 93%. That this has been shown in multiple studies over the years that proficiency-based training has been impactful in helping with FES certification. I'm hopefully not stealing Dr. Ritter's thunder here, and if I am, I really apologize, but this is a great paper. It just came out this past year. And really, he looked at 4 important questions, which is what is the relationship between the time spent on simulation-based training and FES skills test? And it's really kind of plus or minus, depending on the skill that was being tested. Second, which I think is one of the most important these next 2 questions, is simulation-based training required to pass FES? And the answer is no. And is self-reported simulation-based training or self-reported clinical endoscopy training a better predictor of FES skills performance? And really, it's in the clinical setting that's most important, especially with colonoscopies. And has simulation-based training and flexible endoscopy increased since the ABS implemented FEC? And this was a little bit difficult, I think, to bear out in the data that was reviewed. And so this question is simulation-based training required to pass FES, which I think is a concern of many general surgery residency programs that they have to have simulation to be able to have their residents successfully take FES and pass it. And really the answer is no to this. There's no difference in pass rate between those programs that had simulation and those that didn't. And there was really a positive correlation between clinical lower endoscopy experience and FES skills performance. What about residency case volume? So currently, as we all know, the ABS requires 35 upper scopes and 50 lower scopes. The average endoscopy volumes in those passing FES are slightly higher, 63 lower scopes and overall about 103 upper scopes. And so this, the implementation of FES may give us a better sense or a better idea of really the number of cases required for competency, where, maybe in the studies that I showed prior, there was a very large range. And so in conclusion, I would say FES is definitely value added to surgical education. We now have creation of endoscopy curriculum, which really never existed prior to this, and really focus on how important clinical endoscopy is and that experience for our residents, for them to finish their training being competent and skilled in endoscopy, and that it's really an important part of our surgical practice. And that it maybe has given us a better idea of what our case volumes really need to be to determine competency. Kind of a thought about the next steps, given the title of this session, I think is really what is the current endoscopy volumes amongst practicing surgeons now that FES has been out, particularly in the, younger generation of surgeons? Are they doing more endoscopy? What is the impact of the curriculum and the certification on our general surgery residents' confidence in doing endoscopy in practice? Has this changed? And then what is the new benchmark for endoscopy case volume in general surgery residency? Does that need to change? So thank you so much. We'll answer questions at the end, right?
Yes. Okay. Thank you. You can stay here. We'll treat you to the lights.